Muy buenas tardes, tengan todas y todos ustedes. Vamos a dar inicio esperando que se encuentren muy bien, por lo que les solicitamos cerrar sus micrófonos y sus videos, a excepción del ponente y la moderadora, para obtener una mejor recepción de esta transmisión. Asimismo, quiero mencionarles que para realizar las preguntas utilicen el chat y al finalizar tendremos un espacio para responderlas. También les haremos llegar por este medio una liga para que nos apoyen contestando una encuesta de satisfacción. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les damos a ustedes la más cordial bienvenida a la quinta y última sesión de los seminarios de verano del Grupo de Investigación de Terapias Innovadoras en Ciencias Visuales, también conocido como GIEE por sus siglas. Antes de presentar a la moderadora de esta plática, voy a tomarme un par de minutos para hablarles del GIEE de Terapias Innovadoras en Oftalmología y Ciencias Visuales. Este grupo está compuesto por un núcleo de investigadores liderado por el doctor Jorge Eugenio Valdés García, también la doctora Judith Zavala Arcos, el doctor Julio Hernández Camarena y el doctor Alejandro Rodríguez García, además de la colaboración de más de 10 profesores e investigadores. Este grupo se da a la tarea del desarrollo tecnológico e innovación en diagnóstico, prevención y tratamiento de patologías oftalmológicas de importancia nacional e internacional. Esto lo hace con un enfoque multidisciplinario y translacional con tecnología de punta que incluye terapia celular e ingeniería de tejidos, dispositivos biomédicos, nanotecnología y modelos bioinformáticos, el desarrollo de biomateriales y biofármacos, además de investigación clínica y epidemiológica. Algunas de las líneas de investigación de este grupo de enfoque son la ingeniería de tejidos para restauración de estructuras oculares, la investigación de bioactividad oftalmológica de extractos naturales, el desarrollo de dispositivos biocompatibles para la entrega de fármacos, innovaciones en cirugía refractiva, en el diagnóstico y tratamiento de queratocono, manejo de alteraciones de superficie ocular y de complicaciones de cirugía de catarata, además del abordaje terapéutico en infecciones oculares. Algunas de las tareas de apoyo e investigación que se realizan son el desarrollo de proyectos multidisciplinarios que se enfocan en oftalmología translacional, el diseño y desarrollo de dispositivos de aplicación oftalmológica, diseño experimental y estrategias de investigación, la revisión de publicaciones, protocolos y reportes de resultados, diseño de protocolos clínicos y pruebas de validación, y también se da apoyo a programas educativos en forma de talleres, diplomados y conferencias. La moderadora de esta sesión es la doctora Denise Loya García. Ella es profesora de cátedra del programa multicéntrico de residencias en oftalmología del Tecnológico de Monterrey y tiene líneas de investigación en regeneración epitelial, superficie ocular y cultivo celular. En este momento le voy a ceder la palabra a la doctora Denise para que presente a nuestro invitado y coordine su participación.
Hola, muy buenos días a todos. Muchas gracias por acompañarnos el día de hoy. Y me da mucho orgullo y mucha felicidad poderles presentar a continuación al doctor Ali Jalilian. El doctor Ali es un científico clínico y profesor de la Universidad de Chicago, de la Universidad de Illinois en Chicago, y voy a presentarlo a continuación en inglés para también que nos pueda entender un poquito. Entonces, con ustedes les presento al Dr. Ali. El Dr. Ali, he's a clinician scientist with a special interest in a severe ocular surface disease and reconstruction. He completed his medical school and residency at the University of Minnesota, followed by a uveitis fellowship with Bob Nussbaum at the National Eye Institute. He had his cornea fellowship performed with Ed Holland in Cincinnati and a research postdoc at the NIH. He is currently a professor of ophthalmology and bioengineering at the University of Illinois at Chicago, where he leads an active laboratory and transnational research program aimed at developing regenerative therapies for the cornea and the ocular surface. His research has been funded at the NII, DOD, and RPB, among others. He's current editor-in-chief of the Journal of the Ocular Surface, and his notable awards include the Senior Achievement Award from the AAO, Teacher of the Year Award, and the Departmental Faculty of the Year Award. Without further ado, I present you Dr. Ali Jalilian, and please, Dr. Ali, welcome.
Thank you, Dr. Denise, for that nice introduction. it's an honor for me and a pleasure to be with you today and to see you again. Denise, it was great to have you with us during that time that you were in Chicago. And I was also quite impressed by that introductory video, really very impressive. I had heard a lot about your center from our dean, our current dean, Dr. Rosenblatt. But it's the first time for me to actually see what it looks like, and it's quite impressive. Very congratulate you and everyone. So I guess I'll go ahead and get started. And I wish I could. I only wish I could give this in Spanish, but but unfortunately I have to do it in English. But Denise is going to help me learn Spanish so I can do this in the future. Okay, let's go here. Okay, is this local okay? All right.
Yeah, that's perfect.
Okay, so the focus will be on limbal stem cell deficiency, and I'll try to make it sort of start with some basic concepts first. No particular conflicts to report related to this. So again, we'll talk a little bit about limbal stem cells, then what is limbal stem cell deficiency, and what are our current management strategies, and what are some ways we're working on. So as everybody knows, the corneal epithelium is regenerated from these limbal-basal epithelial cells. Here you can see a good landmark are these palisades of Vogt, where the epithelium actually dives in a little bit deeper into the stroma. And it's these intervening sort of stromal areas which show up as these sort of white lines here. But basically this allows the epithelium, the limbal epithelium, to be sort of a little more protected from the surface. And and from there, these epithelial cells, they differentiate and move towards the center, and they follow this sort of spiral pattern. This is the typical pattern of what the epithelium grows, which matches also the pattern of the corneal nerves. And you can image these by in vivo confocal microscopy or OCT. And again, this is the palisades area. OCT is improving the resolution. And I think in the future, this will be really the way we will be imaging most of these patients, will be through OCT. And here again is an example of some of the high resolution OCT pictures, which really gives you almost cellular level detail. I think this, as we learn more and more about what we're looking at, and what this should hopefully help us in the diagnosis and management of these patients. So limbal stem cell deficiency really is a clinical condition where it's either we don't have enough limbal stem cells or the function is compromised. Either way, the bottom line is that the conjunctival epithelium will begin to grow over the cornea. This is a more irregular, unstable epithelium that can lead to defects, and then secondary neovascularization, because conjunctival epithelium, unlike the corneal epithelium, doesn't have the same anti-angiogenic properties. And again, ulceration, scarring. So, and ultimately severe loss of vision. And what are some conditions where we see this? I mean, it's not a very common condition, fortunately, but we see it. I mean, any cornea practice will definitely see these patients. Genetic causes, aniridia probably being the most common, PAX6 due to PAX6 mutations or deletions, some other ectodermal dysplasias. Many traumatic and toxic sort of conditions, chemical injuries, chronic topical medications, chemotherapies like mitomycin C, chronic contact lens wear, particularly soft lenses. We'll talk a little bit about these later. Multiple surgeries, and then these inflammatory conditions, with most everyone's familiar with, Stevens-Johnson syndrome, pemphigoid, chronic uncontrolled atopic or vernal disease will lead to limbal stem cell in general, any chronic limbal inflammation could eventually destroy the limbal niche and lead to limbal stem cell deficiency. So, and what does this look like clinically? Again, with the conjunctival epithelium, initially as it grows in, if you can start to see it's a more opaque epithelium. That epithelium stains with fluorescein, or fluorescein can seep through it. We'll see some, and I guess I'll see some more examples later. And if you really wanted to prove it, you can prove it sort of histologically with impression cytology. Confocal microscopy can also be helpful, again, in cases where you're not quite sure. So just a typical case that one might see in a common practice, a soft contact lens wearer who's been sort of treated with multiple medications, still has this more opaque epithelium arising from the superior limbus. And you can see the sort of staining pattern of this more opaque epithelium that picks up fluorescein staining, vision's down. There's a little bit of superficial neovascularization. And this is the other eye of that patient. And I like this slide because here it shows this sort of punctate pattern here arising from the limbus, this punctate staining here. And this is the earliest sign of stress to the limbus. And what's really happening here, I don't quite know exactly what the process, but either way, it's epithelial cells, clones of epithelial cells that are coming out to the surface that don't have the same properties as the normal cornea epithelium. So I'm assuming that these are more clones of conjunctival-like epithelial cells that are, but it's hard to prove that conclusively. So this is a common situation. Again, I'm sure anyone who's in a sort of practice where they see soft contact lens, where they're likely to see these patients from time to time. Soft contact lens induced limbal stem cell deficiency. And it's multifactorial, and we published a review on this several years ago. Basically, mechanical trauma from the lens in the setting of dryness and friction to the surface, toxicity from preservatives, and in the setting of inflammation. All these things lead to stress and inflammation, ultimately limbal stem cell deficiency, which can become permanent if it goes unrecognized and untreated for a long time. Another patient, again, with limbal stem cell disease related to soft contact lens wear. And you can see this is more diffuse punctate sort of staining throughout the whole cornea. And this diffuse pattern, typically I tend to think maybe preservatives in the contact lens solutions maybe also involved. This is also another example, 360 sort of involvement. So how do we manage these patients? I mean, obviously it goes without saying, you want to stop their soft contact lens wear, but also try to stop. This is in general, how do we treat them? What are some medical treatment options for these patients? You want to stop the sort of whatever's toxic or traumatic agents, the soft contact lens wear. Benzalkonium chloride containing drops, very well known to have toxic effects on the limbal epithelium, especially in a sort of compromised surface, in a dry compromised surface. So glaucoma patients particularly are the ones who are at risk for this. So we try to switch them to non-preserved or non-BAK preserved drops. Obviously optimize tear film as best as you can and suppress inflammation. And typically steroids are the first ones that we'll go to, followed more long-term with other agents, and then systemically if necessary in these other conditions with more severe inflammation. And then more advanced therapies, what can we do for these patients? I think I like to use topical vitamin A ointment at nighttime. That may help a little bit promote differentiation of the epithelium. Autologous serum or plasma drops. And then scleral contact lenses also we use frequently in these patients. Particularly, I have to be careful not so that they're fitted correctly, so there's no, the lens is not touching the limbus and it vaults over the limbal area. So, and because if not fitted correctly, this can actually worsen their limbal disease and limbal stem cell disease. Okay, so in this patient, we have them stop their contact lens wear completely and put them on a course of topical steroids and all this. Unfortunately, most of that late staining epithelium resolved and cleared up. And then we put them on Restasis for long term. So another patient, I'll try to go through quickly since basically the same story. But this one more exacerbated by glaucoma medications and BAK. And we basically did the same thing, put them on preservative-free methylprednisolone eye drops, stop all the glaucoma medication, just switch them to oral agent. And again, all this late staining epithelium regressed. But fortunately, again, these patients had plenty of healthy reserve. But again, patients where it's more extensive, it's much harder to do. This is just showing it. Again, patients with chronic atopic disease, same thing. If not controlled, if their inflammation is not controlled throughout the disease process, as a late sort of manifestation of the disease, which is very challenging to control, or at least is limbal stem cell deficiency. Again, this is another patient with graft versus host disease, very severe dryness, and you can see this is all this sort of this exposure zone and sort of staining, which is from dryness, but this superior staining, this is not just dryness. This is actually stress to the limbus and trauma to the limbus from again, a dry surface, frequent blinking, and leading to this SLK-like picture, which again, if not treated and not recognized, will lead to limbal stem cell deficiency, and which again is hard to deal with. I'll just skip this. Basically, it's just CIN as a sort of differential. Sometimes if it doesn't fit, there's no history here. This is referred as limbal stem cell deficiency, but unilateral, no other history, and really we suspected CIN, which was the case, and we treated with topical interferon. And okay, I won't go through this too much. Basically, keratinization of the lid margins is another problem in these patients that need to address. Yeah, again, a lot of these are review and may not be. I don't want to take too much of your time to tell you things you already know or you can easily read elsewhere. But basically, amniotic membrane for limbal stem cell deficiency is it's reasonable, certainly when it's a more focal sort of disease, but when it's more extensive disease, it really doesn't have a role for the management of limbal stem cell deficiency. So really, the current way that we can treat these patients with more extensive disease is with transplanting new limbal stem cells to the surface. And it depends if it's a unilateral disease, then we can, so unilateral disease we can get from the other. This is showing an example of a patient with aniridia that basically has developed limbal stem cell deficiency, and we took 2 pieces of limbus from the sister of the patient and transplanted to their more severe eye, and obviously they had to be on immunosuppression. I'll skip these in the interest of time a little bit, just so that we can sort of spend more time on some of the other newer things that we're doing. So basically, so this is another approach that's been, and you probably know about, that people have cultured limbal epithelium, take a small biopsy from the healthy eye, then take it in culture, expand it in culture, then transplant it to the other eye with limbal stem cell deficiency. And this will be in the setting of obviously like chemical injuries to one eye. And this, I mean, first published reports are now, I mean, more than 2 decades ago, and this is really have become, it's an approved treatment now in Europe, and the largest series is published by the group in Italy. The main, obviously, downside to this treatment is the price, and because obviously it requires extensive facilities and resources to be able to prepare such a product. So in response to that, sort of the high cost of that, the group in India, Hyderabad, came up with this technique, the SLET, or simple limbal epithelial transplantation, where we take that same small biopsy that we talked about, and instead of culturing it in the laboratory, they'll actually put pieces over the cornea and have the epithelial cells grow over the cornea. And I think that's a reasonable alternative, again, especially if the underlying stroma is clear and they're not going to require a cornea transplant. Then this is for patients who are bilateral disease, and that's really the more challenging group, where there's really, we don't have highly effective treatments. And we have to transplant limbal tissue from, like the example we showed, either from a relative, or like here, we're dissecting tissue from cadaver. I think this is just showing that we basically we secure the tissue and we're dissecting the limbal stem cell, or the whole limbal area, superficial dissection, and then we transplant it to the surface and just use fibrin glue to secure it. And again, this requires systemic immunosuppression, same way you need for the same level that you need for like an organ transplant patient. And the success with these procedures really depends on the underlying disease. The healthier the rest of the surface is, the better these patients will do. And the more severe the surface disease, like Stevens-Johnson syndrome, the more challenging it is to get these grafts to survive long term. And they're both, it's a hostile surface and also at risk for rejection. But in aniridia patients, certainly these are the ones that we have the most success with long term. That and after a few years, we're able to taper off their immunosuppression, especially if they're not a very young patient. And again, whenever we can, we'd prefer this to get tissue from relatives, close relatives with a sibling or a parent or a child, with much closer immunologic match, and reduce the risk of rejection. And rejection is the main challenge, like we said, and again, we've published several papers on those, and the protocol that we use is the same protocol that Ed Holland and Cincinnati has developed, that uses basically systemic tacrolimus and mycophenolate combination, short-term prednisone, and it's gradually tapered off. I try to keep them on something for these really the first 3 to 5 years, maybe at least on mycophenolate. But again, depending on the underlying etiology, and you individualize it based on the underlying disease, the patient age, number of transplants they've had in the past. And Ed Holland has published his sort of long-term sort of results. Okay, so I guess now we're getting close to sort of talking a little bit about some of the things that were, so basically we've shown that these donor cells can survive long-term after transplantation and under immunosuppression. And some patients who stop their immunosuppression or stop their topical steroids, even as late as 6, 7, 8 years, they can develop rejection, and we can see a rejection line. So it goes to show that these, even long-term, these patients are at risk for rejection, and the donor cells are surviving long-term. Keratoprosthesis is another option, obviously, for these patients. These patients are high risk for complications. I won't go into it too much. And I guess I won't go too much into aniridia here specifically. But really, the question here is now, this is now the opening really to the research part of what we're doing. So when we looked at the tissue, the epithelial tissue after transplantation to see whether the donor cells have survived or not, what we find is that there definitely donor cells are surviving, but we're seeing more host cells now contributing to the surface. Meaning that even patients that look like they had pretty extensive limbal stem cell deficiency, once you have restored the healthy environment on the surface of the eye, the host can start to contribute to the surface again. It's still, they're not the, most of our patients, the host cells were not the predominant cell type, but no question that we're seeing host or recipient cells now contributing to the surface in these patients. And that really brings up to this concept of the limbal niche, or the limbal stem cell niche, where, and this is our illustration basically showing that the limbal area, the palisades of Vogt, and it's and the limbal basal epithelial cells here are where the limbal stem cells are, and this is it's a unique, it provides this sort of unique environment for the epithelial stem cells, and it has a more specialized matrix. There are blood vessels, there are nerves, there are other types of cells, particularly the one cell that we were very interested in, what we drew here as these green cells are the mesenchymal cells, which make connections with some of these epithelial stem cells actually, and are definitely, these mesenchymal cells are part of many stem cell niches throughout the body, and they're closely they're often associated with blood vessels in the area as well. So bottom line is, if you have a healthy niche, you're going to have a healthy limbal stem cell function. And in the limbal stem cell deficiency ultimately is really a limbal niche deficiency, or the limbal niche is not functioning properly for those limbal stem cells. So this, maybe some of you have seen this movie, or it's a movie called Field of Dreams. Anyway, this basically the actor Kevin Costner, he keeps hearing this voice in his head that if you build it, they will come. Basically, if you build a baseball field, then these baseball players are going to show up. These are like baseball players who've all died and passed away. They're going to show up to play in this field. It's anyway. So I put this here because the voice that I keep hearing in my head basically tells me that something similar, that if you build that niche, the stem cells will come. In other words, that should be the focus of our treatment, should be to try to restore the health of the niche. If you can restore the niche, then the stem cells will start to show up and function. So this is a little older picture of our group, but basically same way as this group that in the south part of Chicago, where they try to build houses for people who don't have homes. That's what we're trying to do. We're trying to build housing for the limbal stem cells and make new housing for them. So one of the approaches we took, or we've looked at, basically is to try to use to make a decellularized matrix of the cornea to provide the scaffold, the structure for the limbus. And we decellularize the cornea in a way that we don't disturb the matrix. And we maintain many of the key parts of the basement membrane. And we show that, by EM, obviously, that it's maintained, and also that if we culture epithelium over this decellularized matrix, there's definitely a difference between the expression of markers like this P63 between the limbus and the central cornea, showing that at least looks like the basement membrane, at least, there's definitely, we're maintaining some of the limbal characteristics that control epithelial differentiation. And also, again, when we transplant this to the limbus, this decellularized matrix in an animal model, partial limbal stem cell deficiency, we can see partial restoration of the limbus and epithelium. More recently, what we have actually are looking at is actually using a hydrogel, an extracellular matrix hydrogel. So instead of taking whole tissue, turning that whole tissue into basically a hydrogel, and it's a process we published this paper not too long ago in the Ocular Surface Journal. Basically and you're using porcine corneas, we decellularize it, then lyophilize it, turn it into a powder, and then the powder you can reconstitute and when you heat it, basically forms a hydrogel. And here we use it just experimentally in just a wounding model, just to show that we can apply that matrix. Here you can see it on OCT. This is this is the contact lens. This is the contact lens, and this is the hydrogel itself. So we have basically, this is the defect in the stroma, and we apply the hydrogel over this, then heat it a little bit, and it forms this. Then forms a gel, and it's more liquid initially. Then it becomes more solidified gel. Then apply a contact lens, and we can show that it can maintain, that it can help promote healing. Here again, same thing. This is a corneal tissue, which this part had been removed with ALK. Basically, this was for preparing for desect tissue or lamellar tissue, and so we took this and just filled that up with this hydrogel, and that same hydrogel that we talked about porcine cornea hydrogel, and you can get it to fit nicely, and it has basically the same consistency as a cornea on OCT, although again it doesn't have the same mechanical properties of the normal cornea. But anyway, so that's an approach that we're taking to try to restore at least partially the matrix components of the limbus. But also we've been interested in these mesenchymal cells and trying to bring those to the clinic. So these mesenchymal stromal cells, or mesenchymal stem cells, as some people used to call them, these are found throughout the body, in bone marrow, fat, umbilical cord, limbus. And this is what they look like in culture. And they've been, they modulate many aspects of inflammation. Here you can see this showing basically that multiple immune cell types can be modulated by these MSCs. The other nice thing is you can grow them easily to billions of cells. So they're very suitable for cell-based therapies. And they've been, so mostly in animal models, people have shown for the eye, really they can have multiple healing and immunomodulatory effects here in studying an anti-scarring effects. So we've used them in sort of chemical injury models and other limbal stem cell deficiency model. They can definitely inhibit neovascularization, reduce inflammation. There are different ways to apply them to the cornea. Here we're showing it applying with a fibrin gel. We've also looked at other ways we'll talk about in a minute. But people have already been very interested in these cells for multiple sort of indications outside the eye. And these are all the different types of studies, different diseases that people have looked at with the use of these. There are over 1,000 clinical trials that have been registered to date on the use of these MSCs, and some of them getting to more late phase clinical trials. Up to now, there's really no approved product in the US yet, but 2 approved products sort of internationally. One is in Canada for graft versus host disease, and also in Europe for, and so that one is the bone marrow derived MSCs. Again, all of these are allogeneic, meaning that you find a donor and expand the cells from the donor. And then also in Europe for the fat derived MSCs that are using to fix fistulas, perianal fistulas in patients with Crohn's disease. So these are the only 2 sort of approved products to date, but there are multiple ongoing clinical trials. So in the eye, people outside the US have started using these a little bit. In India, in the setting of chemical injuries, people are looking at them. In Spain, people have placed them on the surface of the eye compared to cultured limbal epithelium. So we have started our own study, a phase 1 study, sponsored by Department of Defense, using bone marrow-derived mesenchymal cells, targeting particularly the chemical injuries, but also non-healing epithelial defects. I wonder if I have that. The very first patient looks like I don't. All right, so we've enrolled our very first patient just a couple months ago. A patient with a neurotrophic non-healing ulcer that we injected MSC subconjunctivally, 1 million cells in the clinic, and basically got the epithelium healed after about 6 weeks. This was a defect that had persisted for at least 4 months, despite all standard therapies, including serum tears and contact lenses. So anyway, I mean, it's just one case so far, and we've been things have been slow because of COVID to get this trial off the ground, but we're hoping as things settle down, we'll be able to get this trial underway faster. But another study in parallel that we're beginning is really actually then looking at, seems like the active ingredient of the mesenchymal cells is actually what the way they actually work is through their secreted factors. So by actually taking the secreted factors, we may be able to do the same as what the cells would do. And this, again, there's evidence from animal studies, several from our group. This is in a limbal stem cell deficiency model showing that topical application can try to restore some corneal type epithelium. In this case, there are more red cells. It definitely helps epithelium heal faster. And this is in a phaco-ultrasound injury model of endothelial cell damage that we show that in this model, injecting at the end of the phaco or ultrasound injury, the secreted factors from mesenchymal cells can help maintain a healthier endothelium and prevent endothelial cell loss. So and from all the things that the mesenchymal cells secrete, it seems like the one that people have been most interested in, and it seems to be probably the most important ingredient, is these exosomes, or what also called these extracellular vesicles. And basically, these are these membrane-bound vesicles, about 100, around 100 nanometers in size, that contain proteins, DNA, RNA, multiple, and it's part of sort of cell-cell signaling mechanisms that exist. And we've shown that these exosomes, if you from the MSCs, if you apply them topically, or here in culture, they can make epithelial cells grow faster and heal these scratched wounds faster. They can heal epithelial wounds faster. But also, even more interesting for us, lately we've been looking at their effect on corneal nerves. And it seems like they also help. These are in vitro cultures of corneal nerves. No question that we see these exosomes help trigeminal ganglion nerves. These are from mice. Grow better and have more elongated growth patterns, elongated and complicated sort of dendrites. And then when we tested in vivo, again, we show that we can help restore. Again, these are all sort of pilot studies, really, that still have to sort of be repeated more. But these are pilot studies are showing that in a diabetes model where there's loss of corneal nerves, we can help restore or regenerate the corneal nerves with exosome, and that which correlates with their corneal sensation as well. So So again, based on these encouraging results, we have in the process of starting another clinical trial where we would test the topical application of these secreted factors. And we just got the okay from FDA just about 10 days ago to go ahead and start this trial. So hopefully this will be starting sometime later this year. And just finally, just one completely different subject here, just to think about some of the other approaches that we're trying to take for restoring the health of the surface of the eyes. We've been interested in this PAX6 gene in particular, and PAX6, as you know, is involved in is a major transcription factor that controls the development of the eye and nervous system, and pancreas and other tissues. But in the eye, it's really mutations in a PAX6 leads to the condition aniridia. And there's an animal model, several animal models that have a phenotype. Although it's more of the eyes are smaller. It's called many of these are called the small eye mice. So what we try to do basically is how can we increase the expression of PAX6? So we screened several drugs that we thought are going to be involved in PAX6 regulation of PAX6 expression, and found a particular drug that could enhance the expression of PAX6, and when we applied it topically, we could improve the phenotype of these mice if you give them early in life after they're born. So there's much more detail. I won't go into it. This is our paper that was published late last year on this model. So in summary, limbal stem cell deficiency is ultimately really a limbal niche deficiency, and it can be caused by genetic, traumatic, inflammatory causes. Diagnostically, late fluorescein staining is the most useful diagnostic technique. But I think anterior segment OCT is going to be coming up as probably more and more as we'll be rely on. I forgot to mention this. The other thing that we see on anterior segment OCT is thinning of the epithelium. And that's also another, people have published on that as a strongly correlate with the limbal stem cell deficiency in the conjunctival epithelium, because when conjunctival epithelium grows, it's definitely a thinner epithelium than corneal epithelium. And then management, of course, medical management we talked about, and more advanced management of advanced disease, limbal transplantation. But we're hoping that some of these approaches that we and others are pursuing to try to restore the healthy limbal niche with cells, matrix, and soluble factors will someday be able to provide more effective treatment options for these patients. And I wanted to actually, so my daughter's missing here. She refused to participate in this, but my son seems to know where the limbus is and what his father is working on. And with that, I want to thank people in the lab who did a lot of the work that we presented, funding agencies and collaborators all around the country and the world. And thank you very much for your attention.
Yeah. Thank you very much for this incredible talk. It's amazing how we can see all the years of work you've been doing and putting your heart into it, and we can now see some of the results of it. So congratulations again on your new FDA approved protocol. I know that's such a big deal. And I have a question. I know that with this mesenchymal cells, we have the advantage with the immunosuppression that we don't need as much as immunosuppression as regarding the other ones. So maybe any thoughts regarding this?
Yeah, great question. Yeah, so first, I mean, of course, I neglected to mention that really that MSC trial, we're still looking to sort of work with your center. Once we have sort of gotten through that first phase of establishing safety, then we would looking to sort of work with you, particularly at one of the centers that hopefully we can be studying these patients and these cells in different indications. But you're right. I mean, what the studies are showing really that, of course, so you have two options here when you do mesenchymal cells. Are you going to do autologous or allogeneic? And most studies really show that autologous seems to last better, and maybe the effects are more persistent, and it makes sense. So these allogeneic cells ultimately do get rejected or they die. Either way, their effect is limited. But doing autologous therapy is really quite challenging logistically and really limits the number of patients you could actually treat, given the expenses. So that's why we took this approach of let's study allogeneic. And there's most of the studies that people are doing outside the US and India or Spain, they're using allogeneic cells also. But you're right, here's the way I'm thinking about it is that our hope is that, say, for the time that they are there, they can help sort of restore some of the functionality of the limbus to help the epithelium overcome, let's say, a barrier or overcome a particular pathologic sort of process, then hopefully be able to maintain it even if those mesenchymal cells are not there. But you're right, this is not something that we can think that these cells will be there long term. But I'll tell you the scenario that I'm thinking about, which is sort of our original sort of one particular scenario is the acute chemical injuries. You know, and acute, as you know, all the cells have died. There's no live cells. There's no epithelium. There's no stromal cells, and you need some source of new healthy cells to be there, and it'll be a while before rejection comes around, before even immune cells can you can start to have immune recognition. And so in that meantime, I'm hoping that these cells will help maintain the structure of the cornea, help improve the outcomes of those more severe chemical injuries. But otherwise, many of the indications that we're thinking about, like limbal stem cell disease, probably if we can get this secreted factors to work, that's going to probably be more likely to succeed long term, because then you can keep giving this for as long as you need it. And the cells, probably more short-term indications where you just need to get over a situation. But it's a very good point.
Yeah, that's very interesting. And just another question, do you think in the future we will be able to have them, like, I saw that you put them in eye drops, so is this like where you're trying to go, like your goal is to have them like we can use them in an eye drop form, or? Yeah,
great. Yes, exactly. So, right, that's our goal, that those secreted factors will ultimately become an eye drop. Right, that's the idea. We're still so much that we have to do and learn before this could become really I would say for this next 5 to 10 years at least, this will still be an investigational stage before it could actually become a fully approved product that's widely available. But yeah, that's the idea, to ultimately make this into an eye drop, and we'll see. There's still the unknowns are far outnumbered unknowns, so we'll have to just keep going and learn as we go.
Yeah. Well, thank you very much again. I think this is a very, as you say, interesting topic, and we have a lot to learn from it. And we're very excited for your research, and hopefully we can work together, as we mentioned before. So yeah, we're very excited for that. And again, thank you very much for being here with us, and the audience for being here. And during this summer seminar, we had a lot of topics during this, and we are again very grateful for you being here with us. And thank you very much.
Thank you. Thank you. It's great to see you all. Thank you.
Yeah. Thank you, Dr. Jalilian, for delivering your lecture, and we really appreciate your disposition to be here with us. Thank you. So I'll now proceed in Spanish to close the seminaries. Muchas gracias, Dr. Jalilian, por aceptar la invitación y compartirnos sus conocimientos. En nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, agradecemos a todos su participación en esta última sesión, sobre todo a nuestro invitado, el Dr. Ali Jalilian, por sus importantes contribuciones, que son la voz de un experto. Agradecemos también la coordinación de la doctora Denise Loya. Quiero mencionarles que esta sesión, igual que todas las demás de los seminarios, las pueden encontrar en la Cátedra Abierta Virtual TechSalud. La dirección es catedravirtual.techsalud.mx, así como en el canal de YouTube de TechSalud, en la sección de la Escuela de Medicina. De igual forma, les compartimos la liga de la encuesta de satisfacción por el chat. Y para terminar, los vamos a dejar con un video de nuestra institución. Cuídense mucho y que pasen todos muy buenas tardes.
Para mí como investigadora, la motivación principal es poder mejorar la salud de los pacientes y con ello cambiar sus vidas. El terigión se caracteriza por el crecimiento celular anormal en la conjuntiva, que es la membrana mucosa que recubre el globo ocular. Esta anomalía solo podía corregirse por medio de la cirugía, es decir, por la remoción del tejido.
Buscamos inhibir que las células se transformen de manera negativa, de manera que no crezcan, no proliferen y se mantenga contenido. El ideal sería poder detener su crecimiento y de esta manera prevenir la aparición de esta enfermedad.
Estamos trabajando en las separaciones moleculares de las moléculas bioactivas de la planta siempre viva, una planta endémica de aquí de Monterrey, Nuevo León. Esta planta tiene un amplio uso en la medicina tradicional en México.
Además, hemos determinado en los cultivos las concentraciones de las moléculas que están asociadas al crecimiento del terigión una vez puestos los tratamientos.
Los pacientes con terigión pueden presentar una sensación de cuerpo extraño. Dolor y ardor son otros de los síntomas que también presentan. El terigión llega a avanzar a la córnea modificando las curvaturas, lo que puede inducir a un astigmatismo. Si el terigión llega a avanzar incluso a tapar la pupila, puede llegar a una ceguera total.
¿Qué posibilidad nos da esta investigación transnacional sobre el terigión? Primero, de cambiar radicalmente cómo se trata el terigión, de pasar de la cirugía a un tratamiento farmacológico, pasar de un procedimiento costoso, molesto e incapacitante a un tratamiento simple, accesible y muy cómodo. Cuando uno hace investigación clínica, existe la gran posibilidad de ayudar a un mayor número de pacientes. Puede uno cambiar la práctica de la profesión, introducir un nuevo tratamiento, una nueva forma diagnóstica o procesos de rehabilitación.
Ser investigadora es mi vida, es mi pasión, es una gran responsabilidad.
Investigación que transforma vidas.